So we are on continuation of glaucoma. So let's talk about the classification of glaucoma. The glaucoma is divided into true, juvenile, and infantile. Okay, true, juvenile, and infantile. So true glaucoma means someone having glaucoma from 0 to 3 months. Okay, 3 months. That is true glaucoma. Then comes your infantile. Infantile means 3 years. Okay, so you can take like 3 months to 3 years, and 3 category. So and juvenile means till 13 years of age. Okay, and what is the characteristics of congenital glaucoma? Bopophthalmos. Okay, bopophthalmos. Patient comes with watery eyes, photophobia, and all the feature of bopophthalmos we will be talking about. There is a triad of congenital glaucoma, which says that there is watery eyes, there is photophobia, and there is blepharospasm. Okay, there is blepharospasm. So whenever we talk about congenital glaucoma, so over here, yes, here, so there's a triad, right? So watery eyes, photophobia, and blepharospasm. Whenever we talk about congenital glaucoma can be, this congenital glaucoma, I already told you that there will be true, infantile, and juvenile type of glaucoma, and there will also be, it's divided into a primary category as well as a secondary category. Primary category is the same, the true, infantile, and juvenile. Okay, but the secondary category, okay, the secondary, juvenile till 13 years. Okay, secondary category means it is associated with some other disease, like it is associated with neurofibromatosis as well as Sturge-Weber syndrome. So you can see here the patient who is having hemangioma of the face, hemangioma of the brain, he will have hemangioma of the brain, I have colored it with red. Okay, and he will have glaucoma. And if you see here, over here, this is a case of neurofibromatosis, which is a S-shaped deformity of the lids. Okay, neurofibromatosis 2 will present with leash nodules. Okay, it's not written over here, but they will present with the leash nodules. Now you can see here a case of congenital glaucoma. So how would you differentiate? Do you look this as a retinoblastoma? Somewhat it looks, but it is not white eye defects. Okay, this is not leukocoria. So if there is a differential diagnosis of leukocoria, if you write bopophthalmos, that will be wrong. Okay, so leukocoria, it is seen in the case of congenital cataract. It's seen in the case of retinoblastoma. It's seen in the case of your persistent primary vitreous. Okay, persistent hyperplastic primary vitreous. It is seen in the case of your retinopathy of prematurity. Okay, and different other diseases also. Okay, so you need to memorize all the differentials for leukocoria. So here what we'll see is, this is because of the excessive stretching of the eye, this is a case of like a myopia. Okay, because of excessive stretching of eye, what you can see is there will be break in the Descemet's membrane of the cornea. The break in the Descemet's membrane of the cornea is known as Habs nodule. Okay, Habs striae. Okay, Descemet's membrane, you understand the layers of the cornea, right? The epithelial layer, the Bowman's layer. Okay, and then you have the stroma, and then you have the pre-Descemet's membrane or the Duas layer, and then you have the Descemet's membrane, and then you have the endothelium, right? So that Descemet's membrane which has been broken up, this is known as Habs striae. Okay, in the case of bopophthalmos. So there can also be a Vogt striae. So Vogt striae is seen in the case of keratoconus. Okay, keratoconus, there is Vogt striae. Okay, now what you need to remember here in case of glaucoma is the eye is exceptionally large. Okay, the eye is exceptionally large, because of which there will be subluxation of lens. Okay, so subluxation of lens can be seen. Most common cause of subluxation of lens is actually traumatic cause is subluxation of lens, but it can also be secondary to bopophthalmos. Okay, and there will be a deep antechamber. You know that deep antechamber is a classical hallmark feature of myopia also, but shallow antechamber is a feature of hypermetropia. And you do know that even though there is no lens in the case of aphakia. So in the case of aphakia, we say that aphakia was a condition where there is it's a case of a high hypermetropia, because there is no lens in the case of aphakia. And what happens is 16 to 70 diopters of power is not there, it's not present in the case of your lens, and that's a condition of aphakia, and that's a case of high hypermetropia. And in the case of hypermetropia, there should have been a shallow antechamber, but in the case of aphakia, there will be a deep antechamber. So this was a hallmark. So small key points I will be giving you in between. And remember, copying is also seen in this case. Okay, and remember iridogenesis. So iridogenesis, one more condition, iris moves when the eye moves. So iridogenesis is also seen in the case of aphakia. Okay, iridogenesis is also seen in the case of aphakia. Now you need to remember how you're going to do. You are going to go for goniotomy or a trabeculectomy. So what is a goniotomy? You'll use a gonio lens, and then you'll make a cut. Okay, so goniotomy is done if in the lens, if the cornea is it's clear, but there's most probably the chances the cornea is not clear, right? So what we do is, if the cornea is hazy, okay, if the cornea is hazy, we go for a trabeculotomy. The second choice is trabeculectomy. So trabeculotomy, goniotomy. Okay, so goniotomy is not, it's just preferred when the cornea is clear, and that happens very rarely. Okay, so we have completed this one, right? So let's go to upper part. So whenever we talk about primary congenital glaucoma, okay, so primary cases of glaucoma, so why would there be a primary open angle glaucoma? I already talked about the angle closure and open angle glaucoma from this picture, right? So the angle is open, right? The iridocorneal angle is open, that is why this is known as open angle glaucoma. But here, if the iridocorneal angle is opposing, so if it's closing, that's known as angle closure glaucoma. So what would be the cause of angle closure glaucoma and the cause of open angle glaucoma? So the cause for wait a second. Okay, so the cause for open angle glaucoma is, basically the cause for open angle glaucoma is you're not able to, open angle glaucoma, why would there even be an open angle glaucoma? Okay, so open angle glaucoma means the iridocorneal angle is opened, isn't it, right? So open angle glaucoma means that happens because primary open angle glaucoma and secondary open angle glaucoma, right? So primary open angle glaucoma is divided into, either that can be a normal tension glaucoma or that can be an ocular hypertension, right? And secondary open angle glaucoma is divided into with pupillary block or without pupillary block. So we have already discussed this one over here also. So primary open angle glaucoma, it's ocular hypertension, normal tension glaucoma, and the primary angle closure glaucoma is with pupillary block, without pupillary block. Okay, secondary angle closure also, it's with pupillary block, without pupillary block. This classification is very important. Just memorize it. Okay, so the concept part I'll be giving you. So primary open angle glaucoma, it's more common to someone who is having more IOPs, right? And someone who is having age more than 40 years, and there is the myosin optic gene. Okay, you need to understand about this one, and high myopia. Okay, it's more common to blacks, primary glaucoma. And whenever we talk about the pathogenesis of glaucoma, what happens is, whenever there is this retinal nerve fiber damage, what happens is, basically the astrocytes and the glial cells, they tend to proliferate, and these are actually the supporting cells. Okay, they are the supporting cells, and these supporting cells, they lay down the glycosaminoglycans, making the eye, the neural layer aneural. So what happens is, so if I just show you this in a fundus picture, so it's better you understand the fundus picture. So okay, I'll be marking it over here. See, so when you look into the fundus, right, so I'll come to one diagram. Okay, so this is the optic disc and this one is the cup. Okay, and this is a macula. So for right now, don't think about macula, just keep macula aside. Okay, now this optic disc, this area which I am marking with purple color, okay, this area is actually a neural area. Normally this area is an neural area. Okay, or neural area. So what happens is, because of the proliferation of the glycosaminoglycans and all these chondroid component glycosaminoglycans, okay, what happens is, because of the proliferation of the astrocytes and glial cells, because of the damage of the nerves, all the nerves that was ending over here, so this is an area of nerve. Okay, so this area is area of nerve. Okay, the nerve tend to terminate over here. So what happens is, this area, the nerve is being now, it's replaced by glycosaminoglycans. So this area will increase. Okay, this area will increase. So when this area will increase, taking all the area, so this is known as the Cop-Dix ratio. Okay, so the Cop-Dix ratio, if it's increasing, so if it's more than or equal to 0.7, then there will be a lot of problem. Okay, 0.6, normally it should be less than 0.3. So some people, they have a big eye. So in that big eye, automatically it's large. But what happens is, in those individuals, the cup is actually like this elongated type. Okay, but in the case of your glaucoma, the cup will actually it will increase in this way. Okay, even though it's seen that it's elongated in this particular diagram, but it will actually be like this. Okay, rounded. Okay, now let's move on to the different pathogens. So you can see that it causes compromission of the nutrition, leading to the oxidative injury, which causes apoptosis of the retinal ganglionic cells, killing of the optic nerve, astrocytes and glial cells proliferate, leading to alteration in the extracellular matrix of the lamina cribrosa, remodeling of the optic nerve head, right? So, and the next one is actually the vascular damage. So whenever you whenever you have a glaucoma, like high tension, so whenever you have hypertension also, no, the blood vessels tend to constrict, right? It's the same mechanism. So the constriction of the blood vessels, which is supplying the eyes, basically the retina, right? So enough nutrition will not be there, so they start dying. Okay, that's a vascular theory. Now next, how the patient present with? The patient present with headache, eye pain. Okay, color vision are not basically affected. It's a silent killer. Okay, and what you need to remember is whenever the patient present, just go for a bilirubin test, because the first diagnostic test for glaucoma is contrast sensitivity, and you can also go for an OCT. OCT means optical coherence tomography. If you go for an optical coherence tomography, as well as if you go for this contrast sensitivity test, you can understand that okay, the contrast is also decreasing, and in OCT the nerve fibers are also not abundant, so this person might have a susceptibility of glaucoma. Or you can just see the COP, but the COP, the COP changes will come very very late. That is why it's not that good thing to just see the COP. Just examine the patient with an OCT. Okay, OCT. So any person who is more than 40-50 years of age, right, comes to your OPD, comes to your ophthalmo OPD, so it's better you just go for an OCT. Okay, or you can just go for a evaluation of his eye. Okay, so because it's a silent killer, right? So just look into the contrast sensitivity or the OCT. Okay, contrast sensitivity will be quite cheaper, bilirubin test. Okay, and IP variations, I've already talked about the IP variation. Now how are you going to measure this? So in our hospital also, we have this skystonometer. In our UCMS, we have this skystonometer, which is done by keeping anesthesia. So it's keeping, anesthesia, local anesthetic is given in your eye, and then you use a volt nomogram chart, and then you just compare. Okay, you just keep weights in this skystonometer. So I just wrote this skyma oats so that I could remember sky oats. In sky we have oats, so we are having oats. So skystonometer. The other one is applanation tonometer. It works on the basis of fixed principle. So I have one senior from the same school. He's an ophthalmosurgeon, and he used to often ask me what principle the applanation tonometer works on. So that's fixed principle. Okay, fixed principle. And you need to remember that by applanation tonometer you get fluorescence in eye, right? So whenever the fluorescence, the two margins, so these are the two margins, so these two margins meet at this area like this, which is also shown in this picture. So if it meets like this at this area, this is the IOP. Okay, but the central corneal thickness becomes a role player. So if you have a higher central corneal thickness, then this will IOP will be overestimated. So this is also not that good method. So best method is Perkins, Mechanic, Kaufman's. Okay, or you can also use Pulsar, Tonopen. These are the different methods. Just name is enough for us. Okay, in our level. Let's go to the next model. So you can see here how beautifully that we are looking at the discs, right? So you can see that this is the COP and this is the, so this area, okay, so this area you can see here that this area is a non-neuronal area. The COP area is the non-neuronal area. Okay, and this area which it's been shown here, this is actually the neuroretinal limb. The nerve fiber occupies the neuroretinal limb. Okay, the nerve fiber, it occupies the neuroretinal limb. So neuroretinal limb means all this area. Okay, from here to here, this is the neuroretinal limb. Okay, the COP is considered as a non-neural area. So the COP is actually a non-neural area. Okay, all neural area. So whenever there is actually increase in the glycosaminoglycans or matrix, okay, the non-neural area will increase, right? That is why there's a mechanism of CD ratio increasing, which is known as COPing. Okay, so area of the COP is increasing, that is the non-neural area is increasing if it is remodeling of the lamina cribrosa due to proliferation of the astrocytes and the glial cells. Okay, so there is remodeling of the lamina cribrosa due to proliferation of the astrocytes and the glial cells, right? Now the patient is suspected of glaucoma if the CD ratio is more than 0.7, 0.6 to 0.7. Okay, see, we are waiting till 0.7, so you don't need to wait for 0.7 if you have an OCT. Okay, if you have an OCT. Now remember that whenever we talk about these fibers, this is very, very, very important. Okay? If you don't understand these fibers formula, you will never understand the concept behind central cecal scotoma in the case of papillary edema, and this arcuate scotoma or double arcuate scotoma, which is seen in the case of glaucoma. So what happens is basically you have the superior arcuating fibers. This SAF means superior arcuating fibers, okay, and this IAF is inferior arcuating fibers. So these two fibers, they come from above, okay, from above and from below. So what happens is in glaucoma the inferior arcuate fibers are being much more damaged, okay, and you know that in eye exactly opposite. For example, if you are looking at the nasal side, the temporal aspect receives it, right? If you're looking at the nasal side, the temporal aspect receives it. Similar mechanism. So if the inferior arcuate fibers are defective here, so I'm marking it here, no? So if the inferior arcuate fibers are defective here, what you'll get the damage it, you'll get exactly opposite. So the inferior arcuate damage, the inferior arcuate fibers are basically present in the inferior temporal region, right? So this is the inferior temporal region. So why this is inferior temporal? Remember, macula is always temporal. So at this side you have macula, this is always nasal, okay? So macula is always temporal and it's inferior. So inferior arcuate fibers means inferior temporal, isn't it? So inferior temporal fibers are over here, and what will be the defect? The defect will be superior nasal, right? So superior nasal. So suppose this is this side, okay? Superior nasal. This is a nasal, this is a temporal, this is a superior, this is a inferior. So inferior temporal. Are you getting this? And the superior nasal will be the defect, right? So what defect? What are you talking about? If the nerve fibers is defective, so totally defect. What defect you're talking about? So that means, for example, you're looking at a particular field, right? So you're looking at me, or you're looking at the cursor, the iPad thing, right? And what happens is, particularly at one area your field will be blind, okay? So normally what we do is, in our OPT, if you do not have any kind of setups, you just go for a confirmation test. You ask the patient to close the same part, and then you just look into, are you able to see this? No, I'm not able to see. No, I'm able to see, like this. You just go on. So if you close your left eye, just ask the patient to close left. Right eye, okay? So you just, you go for a confirmation test like this, right? Confirmation test. Okay, so but if in case you have to understand the visual field, right? So, but if you have been through physiology lab in UCMS, what do we have is, we have Lister's perimeter in the physiology lab, and one of our physiology assistants, she helps us doing the Lister's perimeter, and she gives us the report in somewhat like this kind of chart. I don't have the chart exactly, but she gives you one report like this, and you tend to paste it in your file, isn't it? So that's Lister's perimeter. Now, what you need to remember is, suppose you paste the Lister's perimeter in your chart, and then you visualize that. What is there in the Lister's perimeter? First, I have to tell you that, then only you'll understand. So it's like this, right? So the Lister's perimeter is like this. So this concentric circle is known as the isopter, okay? The concentric circle is known as the isopter, and the area between 10 to 20 degrees is actually your blind spot, okay? The area between 10 to 20 is your blind spot, okay? And then actually that blind spot is actually that area. It's always a blind spot. So what you do is, you just exactly at that particular area, it's a blind spot. So why will there be a blind spot at that area? Because that area is actually denoting the optic disc in your eye. So at the area of your optic disc, you'll have a blind spot, right? That is why whenever there is optic disc haziness in the case of papillitis or papilledema, what happens is, the blind spot, it will enlarge. So there will be enlargement of the blind spot in the case of papilledema, right? Just correlate things, okay? So it's like a revision. You might be not understanding anything, but if you just recap it 1,000 times, you'll understand. I also did the same thing. Now let's move on to the ISNT rule. So I'll just do this in the next session, okay? So now let's talk about the ISNT rules, right? So normally what happens is, the optic disc, so there's an optic disc, right? So over here I'll show you. So there's the optic disc, the disc cup ratio which you see, okay, the disc cup ratio which you see over here, this is, it looks like it's same all the area. It looks like it's all same all the area, but it's not that the case, okay? So ISNT means the inferior is slightly larger. Suppose it's like this, the inferior is slightly larger, and then comes the superior, and then comes the nasal, and then comes the temporal, like this, okay? So in this way it's designed, but indeed the cup, whenever we just demonstrate, we just do it like this, right? So there's this ISNT rule which is being followed by the normal cup and the disc, right? But what happens is, that ISNT rule isn't followed actually, okay? That's ISNT rule this IS&T rule is not actually followed. Because of which, what happens is, because of which normally what you see is it starts from the inferior side, the cupping, it starts from the inferior side, and in the inferior side you see a slight notch, and that notch is an important hallmark. Okay, you should understand about that notch. That is known as notching. So the neuroretinal rim in normal eyes show a characteristic configuration. It is usually broadest at the inferior rim, followed by superior nasal rim, and thinnest at the temporal disc. Okay. The pattern of the rim width is IS&T rule: inferior, superior, nasal, and temporal. IS&T: inferior, superior, nasal, and temporal. When there is cupping, there is damage of the arcade fibers. See, when there is cupping, there is damage of the arcade fibers. You can see there, I was talking about the same arcade fibers. The size of the cup have increased, so eye is lesser, so glaucoma does not follow the IS&T rule, right? If the cupping happens only inferiorly, the outer rim is lost, and it is known as notching of the neuroretinal rim. So glaucoma doesn't follow the IS&T rule, and there is notching. Just remember that. And whenever the lamellae, these are the lamellae which are basically entering to the eye. So what happens is, basically there are nerves which are entering through the eyes, and these nerves are actually traveling through a laminar area, okay, in your sclera. And what happens is, whenever the nerve will actually degenerate, these area which is present in your sclera, the dots in your sclera, becomes much more prominent. So you're not understanding this, right? So I'll make you understand, don't worry. So suppose this is your dots which is present in the sclera. Okay, this is your dots which is present in your sclera, and then what you have is, you have your nerve, right? So you have a nerve like this. So initially your nerve is like this. By this nerve you are not able to see that area. But what happens is, because of nerve thinning, right? Now nerve has become thinned out, right? So nerve is only like this. So what you are able to see is, yes, you are able to see that the area from where the nerve is transversing, and that is now this becomes like this. Okay, so this is before, this is after. Okay, so the nerve has become thin, and because of which the area of entrance is basically seen. It's similar to that of your, like, whenever you become thin, lean and thin, after a fat person becomes lean and thin, all the jaw lines are basically seen. His abs are seen. Abs, I also have abs, but it's not displayed, right? Why it's not displayed? Because I have fat in front of it, right? But I do have an abs, right? I also have rectus abdominis muscle, right? So that's the thing. Now let's talk about other important component. One is the nasal sifting of the blood vessels. Now what happens, what is this nasal sifting of the blood vessels? And there is one nasal sifting of the blood vessels, and there is one bionating sign. Okay, bionating sign and nasal sifting of the blood vessels, these are important hallmark which is important for you to understand. Okay, nasal shifting of the blood vessels means the blood vessels will shift nasally. The blood vessels will shift nasally. And one more thing you need to add upon is, whenever you talk about nasal shifting of the blood vessels and all these things, you need to talk about that there's a bionating sign. Bionating sign means the retinal blood vessels can disappear as they turn sharply into that sharp bending is actually known as the bionating sign, because of extensive for example, there's a blood vessel, you're continuously moving that blood vessels, you're continuously twisting and turning a pipe, right? So there's a pipe and you're continuously twisting and turning that pipe over here and there. What will happen? That pipe will rupture, right? So there'll be splinter hemorrhages. Okay, that's basically spleen-shaped hemorrhages, right? And there's the alpha zone is there and beta zone is there, and beta zone is associated with glaucoma. It's just you can understand that, right? Now see here, this is a 90 diopter lens. Okay, 90 diopter convex lens, which is used to see your fundus. See here how beautifully the doctor is taking the lens and she is looking at your fundus. So let's suppose this is my lens, even though it's not hollow from the other side. Suppose I this, oh, please look into my ears, and now let me look into your eyes. Okay, it's okay. Just look into my ears, look into, yes, I'm able to focus here. Fundus. So there's no cupping. I see it in that. That's the reason I'm looking at a fundus. Okay. So that's the reason I'm using this lens to look into your retina, to look into your vitreous, right? Through your pupil. So I just want to dilate your pupil so that I can easily look into your fundus. So 90 diopter is the best lens, or you also have 60, 78 and 90. Okay, out of which the 90 is the best one. Okay, and the method is, you can actually Okay, now let's come to OCT first of all, and we'll talk about that later. So OCT, I already told you that initial changes occurs by the nerve layer, right? So you can just go for a nerve examination, and if you talk about the visual field, maximum things I've already told you. Now the most important thing I'll tell you. Okay, so suppose this is a blind spot, right? So this is a blind spot. The blind spot is there. Temporal aspect. This is a nasal aspect. Now you might be thinking the disc is nasal to the macula, and you said that initially the statement was there that the disc was the area of the blind spot. So why in earth the visual in this visual chatting the blind spot is an area of the temporal. So that's actually a rule, that's actually a presentation. So it's like basically whenever I say like whenever you sit in front of the patient, your right hand is actually the patient's left area, right? The same mechanism here also. Okay, so I'm actually looking in this way that the blind spot is temporal and the other area is disc, but actually the blind spot, it denotes the area of disc. Okay, and I already told you in the initial lectures also, it's difficult to understand, I know, but if you continuously revise, it will be easier. So what happens is there's a condition which is known as papilledema or papillitis, where there's an papillitis means an inflammation. Let's not talk about papillitis, let's talk about papilledema. It's basically disc edema. So optic disc which you see, there will be disc edema, not copying and all, there will be disc edema. Okay, there will be leakage of the blood vessels, and because of which the whole disc will be edematous. And because of the edematous disc, the edematous means enlargement, right? So if your hand becomes edematous, the hand will be so large, right? Similarly, the disc will be also so large. So in the visual field, what is the disc? The disc is the blind spot. So the blind spot will actually enlarge in that case. Okay, very good. Now let's talk about the different visual field defect in the case of your glaucoma. Okay, so in your visual field defect, what you need to understand is you have your blind spot. Okay, blind spot, and I already told you that the defect is an inferotemporal fiber. So inferotemporal fibers means superior-nasal fibers are being defective. So in this area, this is temporal, this nasal, this superior, this inferior, right? So where is the inferotemporal? The inferotemporal is somewhat over here, right? So the defect will be over the superior-nasal over here. So superior nasal will be defective, right? And when that superior nasal area will be defective, that is known as Zerum's area. You can see here, Zerum's area, okay? And that area of scotoma is known as a paracentral scotoma. Paracentral scotoma. Why is this word paracentral scotoma? Very funny, no? Paracentral means central scotoma is there, centrocecal scotoma is there, which happens because of the destruction of the papillomacular bundle. Where on earth is this papillomacular bundle? Right in this figure, I showed you. This is the papillomacular bundle, and these fibers are actually damaged in the case of your papillitis and papilledema. Okay, so in glaucoma chapter also you will know about neuropathal that in the case of papilledema or papillitis, what will I see? I will see a centrocecal scotoma. Excellent. Now let's talk about this one. So superior-nasal defect, inferotemporal and superior-nasal will be defect. Now what will happen on soon time is this blind spot and this area of defect, they come to lie against each other, okay, like this, like good friends. They come to so close to each other, very, very close to each other. So I feel that this is like a seedle, right? You have seen like this kind of there's one sickle type, no? Like from there's word the seedle kind of scotoma. Now afterwards, what happens? This enlarges, okay? This enlarges, so this becomes more. So it looks like an arc. And that arc is known as arcuate scotoma. Okay, and what happens is soon after, the arc will be on down also. Now what is this? This is a double arcuate scotoma. Up also scotoma, down also scotoma. Double arcuate scotoma, right? And what next? Now there's double arcuate scotoma. Now will the central vision go initially, or the peripheral vision go? The central vision will persist till late. Okay, the peripheral vision will go. Initially the peripheral vision will go, and the central vision will stay for last time. Okay, so that is the classical hallmark of glaucoma. Okay. So what do you have? You'll have arcus scotoma, you'll have double arcus scotoma, and then the central and the temporal island of vision seen before the blindness. Okay, so central and the temporal island. So there is other also, like Rosen's nasal step is there, serial scotoma. So in the case of your exam, if you just explain this much, it will be more enough. Okay. Now perimetry. So perimetry, you have a static and you have a kinetic. Okay. Static means Humphreys and octopus. Humphreys and octopus are not available in our college. Okay, Humphreys and octopus are available in very good centers. Okay, where you just have to put your chin like this. Okay, one of my optometrist senior told that you have to actually put your chin like this. So suppose this is your this one, you have to put your chin like this. It's all covered like this. It's all covered, and whenever you see some light, just click like this. Okay, this is the octopus or Humphreys. Okay, sorry, octopus or Humphreys. Yeah. And you can also go for kinetic. In kinetic, what do you do? Conformation test. So how you are looking or not like this conformation test. You can see here conformation test. How we will do this is taught in the practical session. Okay, you can study from your practical people. So this is your confirmation examination. You can also go for Zeram screen, and the test which was done in UCMS is Lister's perimeter, somewhat like this, but there's no like big screen. They have that Lister's perimeter, and just move on, and they just chart it on your A4 size paper, and you have to paste it in your physiology practical. Okay, now let's talk about the changes in a tabulated form. See, so if there are, there's a question that write about the changes that you see in the glaucoma, just paste this, you'll get good marks. Okay, in exam. Finish. Now let's talk about the last. Okay, so glaucoma part 3. Now whenever we talk about glaucoma, next thing that we have to talk about is angle closure glaucoma. So what is angle closure glaucoma? Angle closure glaucoma means the iridocorneal angle is now, it is actually obliterated. The iridocorneal angle is obliterated. So what does that mean? That means particularly you have an iris and the choroid, right? So you have an iris, and then you have your iris, and then you have your cornea, right? So there is an angle. There's an angle subtended, but now this angle will be obliterated. Now, what are the different reasons by which this angle will be obliterated? What might you think? You just think it off. Suppose if this angle is by birth, it's small. Okay, small. I recently told you shallow anterior chambers was a classical hallmark of hypermetropia. So someone is having hypermetropia, number 1. Hypermetropia is usually seen in which eyes? Small eyes, nanophthalmic eyes, number 2. Number 3, what's posteriorly over here? You have your choroid, right? You have the choroid and all, you have this one, right? So if I just push your lens forward, so what the lens is somewhat like, it's like a biconvex structure, like it's a biconvex structure. It's like this biconvex structure. What if you have a like much more thicker lens? So if the lens is too much thick, too much fat lens, there's nothing known as fat, but if the lens is too thick like this, too large lens, right, that might also close the angle, right? So anything in plateau iris means actually flat iris. Okay, so it's quite a lot difficult to make this point understandable, but I'll try to make it understandable. Okay, I took too much time to understand this plateau iris. See, whenever there is flat iris, it pushes the lens forward. What happens is there's an obstruction. So just try to memorize. Okay, suppose you take this part. Okay, suppose you take this part, this area like this. Okay, so suppose you take like this, suppose this hollow area, you take this area like this. Okay, this is your iris. Suppose this is your iris. Okay, this is your iris, same iris, no? Now if you look into the diameter of this iris, now if this is a cylinder, right? If you have 3 divisions, this is a cylinder. But what happens if you just press it off? If you make it thicker, the diameter, I mean the length which was actually seen here, the small length will now become enlarged, right? There was a small length when it was a cylinder. But when it, when I just compress it, when it just become flat like this, so your iris was like this, now it becomes flat like this. So it takes more area, no, more area. But actually the area is, suppose in a car there is occupancy of 4 people. Now if there sits 8 people, there will be congestion, right? So iris will be like this, it's okay. But when the iris becomes like this, flatter, you can't accommodate, so there will be angle closure glaucoma. Okay, so that was the best way how I could explain. Next, it was small eye. Okay, when nanophthalmic eye, hypermetropia. It's more common to females, right? And it can be of with pupillary block, with a pupillary block, and combined mechanism. Now, what you need to understand is, suppose there is pupillary block. Okay, suppose there is pupillary block. So the pupil has been blocked. What happens? The aqueous from the posterior chamber now cannot go to the anterior chamber, right? Because of which the aqueous will collect in the posterior chamber like this, right? All the aqueous in the posterior chamber. That will lead to bowing of the iris. So bowing of the iris like this. Bowing of the iris. And this bowing of the iris is known as iris bombay. And there's a classical feature is seen in the case of anterior uveitis. What is this anterior uveitis? A long story to go. You'll understand in the case of uveitis, okay? So, iris bombay and increase in the lens wall, increase in lens thickness. So, plateau iris, we have understood about this one. You can go for a USG biomicroscopy examination, okay? USG biomicroscopy examination, there's an anterior chamber examination as well as a posterior chamber examination. So, if you just look into the anterior chamber, you can just look into the what is the configuration. So, how can you assess the angle? So, iridocorneal angle. So, you can assess it like this, okay? Assess it like this. So, what comes is, one is the Squalvis line, pigmented epithelium, non-pigmented epithelium, pigmented epithelium. Then comes your scleral spur, ciliary body band, and iris. Okay, so So ICST, you can remember with this mnemonics. There was a very good mnemonics given by Dr. Shashwat Ray, but Shashwat Ray sir, he gave a very good mnemonics, but I forgot that that mnemonics. Mnemonics tend to become, when you make a lot of mnemonics, you tend to forget that mnemonics. That happens, right? So, scleral spur, pigmented, non-pigmented epithelium, pigmented epithelium, and then you have sclera, ciliary body, and then you have iris. Okay, sclera, ciliary body, and iris. And if you look into all the layers, if you are able to look at all the layers, excellent, angle all open. But if not able to look some layers, it's given by the Schaffer's grading system. There are different other gradings also, like Schaffer's, Van Herrick, right? And USG biomicroscopy examination, structure behind the iris can be seen, right? And anterior segment, optical coherence tomography, you can do that, right? Now, gonioscopy, before understanding this, you need to understand that 46 degree is actually your critical angle of the cornea, okay? So, detail on this, a lot of physics to go, because of the total internal reflection. Like suppose if I look from the slit lamp examination, because of the total internal reflection, I'm not able to see that angle. But when I use this beautiful lens, the gonioscopy lens, okay, I'm exactly able to look at this angle, which is actually explanatory by this diagram, right? So I'm able to look at that diagram, that angle. That is why gonioscopy lens is basically used to assess the angle. Okay, so you can actually look into that angle directly, or you can use certain lens to understand. Okay, so if you go for a direct visualization, that is known as Copies and Swann-Jacob, and if you go for an indirect visualization, that is known as Goldman's lens, Zeiss-Susspan. Okay, Goldman Zeiss-Susspan. Okay, Goldman Zeiss-Susspan, and this one is Copies and Swann-Jacobs. Now, if you understand this Schaffer's regarding system, see, if no structure is visible, it's 0. Squalvis line, tabular meshwork, ciliary spur, ciliary body. Simple, right? Squalvis line, there's no iris over here, okay? Squalvis line, tabular meshwork, scleral spur, ciliary body, and then you have iris. So 5 structures you had, right? So out of 5 structures, that trabecular meshwork is divided into non-pigmented and pigmented. But here it's just a trabecular meshwork. And 0, 1, 2, 3, 4. That's the ACA grading. ACA grading. Okay, there's this something which is known as the Van Herrick method. There's this Van Herrick method, which is actually the method by which we can examine the angle. Okay, the Van Herrick method. Now let's talk about the different types of angle closure glaucoma. It's a very, very important topic. Okay, so angle closure glaucoma can be divided into primary angle closure suspect, and then you have primary angle closure. They have acute congestive glaucoma, and then you have chronic glaucoma, and then you have absolute glaucoma. And this is like a Mahabharata. Now it's like a story also. I'll help you out to understand all these things. Just listen to me. Now, before understanding this, you need to understand about the occludable angles. So, what is actually occludable angles? Occludable angles are basically the angles when you look into the 180 degree, you take a turn and you see 180 degrees as a whole, right? So, whenever you see as a whole 180 degrees, at the area where the post-trabecular meshwork structures are not visible, which is known as occludable angles. So, it's written here at the definition of occludable angles. So if the post-trabecular structures are not visible more than 180 degrees, right? So you just look into the 180 degrees all over, and more than 180 degrees if it's not visible, post-trabecular meshwork. So that is known as occludable angle. So if it's divided into 4 quadrants, 1, 2, 3, 4. More than 3 quadrant of your occludable angle if it's there, with no peripheral anterior synechiae and no raised IOP. So iridotrabecular contact is there. That means, okay, suppose this is your eye. This is your eye. I divide it into 4 quadrants. This is 180 degree. This is the another 180 degree, right? So I examine, and 1, 2, 3, 4. I see occludable angles in 3 quadrants. 3 quadrants like this. Iridotrabecular contact or occludable angle of more than 3 quadrants. More than 3 quadrants. Okay, then that is on gonscopy. That is known as primary angle closure suspect. Okay, without any peripheral anterior synechiae, or there is intraocular pressure is normal. The patient is just at risk of developing glaucoma. And what you do is you just throw a light through this area. What happens is this light, which will actually eliminate the area over here, over the lateral aspect over the eyes, where the light is being thrown. The area which is being hidden will actually become like a shadow. That is known as eclipse sign. You can see here. See, the light is being shown. This area is illuminated, but this area is dark, and this is known as eclipse sign. This is known as eclipse sign. It's a classical hallmark seen in glaucoma. Okay, so just go for a prophylactic iridotomy. What is this iridotomy? Iridotomy means making a hole in your iris, and that is done by the Nd:YAG laser. You just make a hole in your iris. Okay, and you have acute congestive glaucoma, and then you have primary angle closure glaucoma, chronic glaucoma, and absolute glaucoma. Okay, now let's talk about the primary angle closure. So what happens in the primary angle closure? In the primary angle closure, the occludable angle is more than 3 quadrants. Peripheral anterior synechiae may be present or absent, but IOP is raised. So go for a prophylactic iridotomy and control the IOP by certain drugs like timolol, betaxolol, okay, levobutanol, or you can give better drugs, right? Prostaglandin analogs can be actually given, right? So what do you mean by acute congestive glaucoma? Acute congestive glaucoma means someone who is having primary angle closure, or someone is having glaucoma itself. It's much more precipitated. It's actually an emergency condition. It's actually precipitated. Now, why is it precipitated? So, this glaucoma, this angle closure, it occurs morely in the mid-dilated pupil. And where you will find a mid-dilated pupil? Of course, you'll find the mid-dilated pupil in the case of your, in the case of dark room, right? Dark room, or if you are afraid, right? Or if you are using certain mydriatics in the eyes, right? Or you are using topicamide, okay? Drugs like topiramate, okay? Or sympathomimetics type of drug if you're using. What happens is, because of that, the eye will be so red, so congested, so painful, and the patient will come with so red eyes, okay? So the patient will come, I'm having so pain, and you just look in the eyes, so red. And you take history, and by history you find out that the patient was a patient of glaucoma, and initially she was watching a horror movie. For example, she was watching a horror movie, and that happens instantly. Okay, now what do you say? You just see total, the IOP has been so raised. If you just take a Perkins, and if you measure, the IOP becomes like 70, 80, and that's so more than the stromal pressure, the corneal stromal pressure, and the cornea can't, there's no, that pump mechanism cannot operate in the cornea, because of which what happens is there'll be imbibement of the water inside the cornea, and that'll lead to corneal edema, right? Cornea will be hazy, number one. Number two, very, very red eyes. Number three, you're not able to assess the cup because of so much blepharospasm, so much eye erythema, so much like tension in the eye, right? But when you are able to assess the cup, it will be totally cupped, okay? The cupping will be so high, 0.8, 0.9, sometimes 1, okay? So much of cupping. And what happens because of the excess, this one, all the 360 degrees angles are actually obliterated, right? And shallow angle. Why shallow angle? I already told you the risk factor for angle closure glaucoma is having a small angle, small antechamber, right? Now how will you just keep the patient supine? You'll give IV mannitol, decrease the intracranial tension, and then only you'll give acetazolamide, okay? Then only you'll give acetazolamide. So there's this protocol over here, see? IV mannitol is given 1 to 2 gram per kg body weight, 1 to 2 gram per kg body weight. Then what you give is, you'll give glycerol. So you'll give 1 to 2 gram of per kg body weight mannitol you'll give, or you can also give glycerol, and then you'll give acetazolamide. Acetazolamide 250 mg tablet, okay? And after that, what you'll give is, you'll go for pilocarpine, okay? So if you give pilocarpine in initial circumstances, what will happen? There will be iris ischemia. Iris ischemia will be there. Don't give pilocarpine initially, okay? And next thing is resolved primary angle closure glaucoma. So what is resolved primary angle? That means you had a primary angle global glaucoma. Now it's resolved. What will you have? You'll have Vogt triad. So Vogt triad is actually the break in the Descemet's membrane of the cornea. Vogt triad means there'll be glaucoma flecken, there'll be dispersion of the pigment of the cornea, and iris atrophy. Okay, iris atrophy, dispersion of the pigment of the cornea, and glaucoma flecken. Glaucoma flecken is actually the cells, the A cells basically, which is present in the anterior cortex. These are actually, atrophied. So that is actually known as glaucoma flecken. The epithelial cell infarcts. Okay, epithelial cell infarcts. So you can see that I've made the beautiful lens, and that epithelial cell has gone into infarcts. Okay, and there will be iris atrophy. Iris atrophy will be there, and there will be Descemet's membrane fold. There will be excessive stromal edema. In the cornea, glaucoma flecken, cataract is a Vogt triad. Vogt triad means glaucoma flecken, dispersion of the pigment of the cornea, and of course there will be iris atrophy. Okay, please don't forget. I had forgotten it, so you don't forget. I should also not forget. Glaucoma flecken, corneal edema, dispersion of the pigment of the cornea. Okay. Now primary angle closure glaucoma, this means there's an occlutable angle. Of course, PS is there, high IOP is there. Now, primary angle closure glaucoma, there is optic neuropathy. Optic neuropathy has started, okay? Now, along with optic neuropathy, if there's visual field defect, that will be chronic glaucoma, okay? Raised IOP, fundus changes is there. Now, visual field defect, along with optic atrophy, that is a chronic glaucoma. And there's something which is known as absolute glaucoma. Absolute glaucoma means it's a painful blind eye, okay? Painful blind eye. So much 100% cupping, so much pain. The eye is stony hard on palpation. What do is you just go for cyclotherapy, and you just injure all the ciliary body, which is responsible for causing this aqueous production, because of which what will happen, the pain will subside, but there's a high chance of going into phthisis bulbi, blind shrunken eye. Okay, but what to do? Problem everywhere, there's problem, no? Okay, so chronic glaucoma means visual field defect. See, visual field defects are seen in the chronic cases, right? But primary angle closure glaucoma means there is optic neuropathy, right? And what you need to understand is cyclotherapy is given 2.5 millimeter from the limbus by using laser or cryotherapy. Damage the ciliary process, therefore the aqueous is formed less and pressure is controlled. So it's 2.5 millimeter from the limbus, okay? And what do you now understand about the retrobulbar injection of ciliary absolute glaucoma can sorry, retrobulbar injection of absolute alcohol could also be given, but now it's not done. Peripheral iridotomy, 11 to 1 o'clock position should be chosen, and it's given in the thinnest part of the iris. So thinner part of the iris is towards the upper segments. Okay, that's the crypts of the iris. Okay, don't give laser in such a way that there will be iridodialysis. Okay, just give laser precisely at the thinnest part, just one laser, finish. Okay, and you can use some lens which is known as Abraham's lens, that is 66 diopters. Okay, a 90 diopter lens was that convex lens. Now let's come to secondary glaucoma. So from secondary glaucoma, we will do in the next video. Main important was that one. So before this, I would like to talk about the treatment for glaucoma. Okay, so treatment protocol of glaucoma. I think, and after that, we will in the next session we will talk about the. Actually, we will talk about the important things. Okay, treatment of glaucoma will be in the next session. Okay. So again, welcome to you all, and now our session is on the treatment of glaucoma. Okay, so the treatment. So how are you going to treat the case of glaucoma, and what are the different drugs that are we going to give in the case of glaucoma? See, anti-glaucoma drugs. See, glaucoma has basically medical treatment as well as surgical treatment. As I told you in the case of congenital glaucoma, that we could go for either we could go for goniotomy if in case the cornea is clear. If in case the cornea is not clear, we have to go for trabeculectomy, right? So I've already told you that portion, right? So the most important drugs is actually beta adrenergic blockers, alpha blockers, alpha agonist, beta blockers, alpha agonist, and then you have PJ analogs. Okay, PJ analogs will learn in the same way, okay, like I'm saying you. And then you have carbonic anhydrase inhibitors, and then you have myotics. Okay, myotics. Now, first of all, we'll talk about the beta adrenergic blockers. Okay, so beta blockers like timolol, betasolol, levobunol. So these come under a precise quantity. For example, these beta blockers. So first of all, we'll talk about PG analogs. Okay, PG analogs. Let's forget about PG analogs. Now, why was I talking about PG analogs in the first? Why did I say that the first drug? Let's talk about PG analog, because PG analogs are the best drugs. Okay, they increase the uvoscleral pathway. Okay, they increase the uvoscleral pathway, and they are available in, suppose, latanoprost. It's available under 0.005%. Okay, 0.005%. Okay, latanoprost. And these, they are the first choice of case in the case of open angle glaucoma. So if in case you have an open angle glaucoma, or you have to use any kind of drug for glaucoma, just use latanoprost. Very good drug. Okay, IOT is reduced in ocular hypertensives also. Okay, so if in case you are ocular hypertensive, it's reduced in both ocular hypertensive as well as normal tensives. But the side effects. Now, the most important thing is how to memorize the side effects. So difficult, no? So what we'll do is we'll just make a diagram. Okay, make this diagram along with me. See here. What you can see is with the red color pen, just make like this kind of diagram. Okay, and again with the black color, you just make this like this. Okay, and over here we'll make it like this. So what is this? See, the eyelashes has been thickened, and this reddish means certain like redness. So when you have redness, you'll have irritation, right? Irritation. And you make like this. What am I making this? I'm making the fundus. Okay, and at the fundus area with the blue color, you just make this blue color, and then with the blue color you just go for it like this. So what is this? I'm showing you macular edema. Okay, so there will be eye irritation, thickening of the eyelashes. Okay, eyelashes thickening. Okay, and there will be macular edema. There will be pain. Okay, ocular irritation may be there. So, and if you talk about bimatoprost can increase both outflow trabecular as well as uvoscleral outflow. And hypertrichosis is the side effects, and latanoprost can cause heterochromia iritis. Okay, latanoprost can cause heterochromia iritis. Now, if you can remember this many, you just remember. If you can't remember, don't remember. It's up to you, okay, but it can come in PGMCQ, so you have to remember. Okay, so latanoprost, it can cause heterochromia, iritis, and bromatoprost can increase both trabecular as well as avascular pathway. Usually less side effects with PG analogs. Okay, now let's come to beta blockers. So what we'll use in beta blockers, we'll use timolol, betasolol, levoponol. Okay, and what you need to know is the IOT, the intraocular tension, is reduced by decreasing the aqueous formation. Okay, in the case of beta blockers, what we do is we decrease the aqueous formation. Okay, and what you need to remember in the case of beta blockers is, again, in the beta blockers, the same diagram. We'll take a black pen, whole diagram, and in this beta blocker, you just need to fill this with the red color. Now, why am I filling this with red color? Because there will be redness, okay, there will be redness. Along with the redness, there will be blood vision. Okay, redness and blood vision. And remember that whenever you talk about beta blockers, it can reach your systemic circulation. So to prevent it from reaching your systemic circulation, just press towards the medial canthus for some time after you put on a beta blocker. Okay, why? Because if you use a beta blocker and if it goes to the systemic circulation, it can lead to bronchospasm. Okay, bronchospasm. It can lead to bronchospasm, and that will be a huge hassle in the case of someone who is asthmatic. And do not use it in the case of someone who's having heart problem. Okay, heart problem, contraindicated in COPD or bronchial asthma. Okay, and corneal aesthesia is one of the feature. Okay, hyposthesia or corneal aesthesia, that means the anesthetizing, like whenever you talk about the corneal aesthesia, that means the cornea, the reflex mechanism will be actually less in the case of beta blockers. Okay, reflex mechanism. Whenever we talk about alpha blockers, alpha adrenergic agonist, okay, not alpha blockers, alpha agonist, what do? Is they just, they increase the avascular pathway and they decrease the aqueous formation by, But what's the problem? So alpha agonist, all with epaclonidine, brimonidine, okay, and brimonidine is really, sedative. People sleep with brimonidine, drowsiness. Okay, it's contraindicated in children because it can cause sleep apnea also. Okay, so it's can be given in pregnancy. And epaclonidine and all this, just make this diagram. Okay, make this diagram. So make a big diagram over here. Eyes is there, and then above your palpebral and just make like this. So what is this? You're having papillary lymphoid follicles are there, and there will be lid dermatitis. Okay, lid dermatitis with epaclonidine. Sorry, there will be lid dermatitis with epaclonidine. Okay, and we can use also carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors are responsible for decreasing aqueous formation. Carbonic anhydrase inhibitors like brinzolamide, dorzolamide. Okay, carbonic anhydrase inhibitor, brinzolamide, dorzolamide. And then you have myotics. Okay, so how are you going to treat the case? So first of all, you will use PG analogs. Okay, so start with monotherapy with latanoprost or topical beta blockers. If target IOP is not attained, then you can use alternate drug. Okay, or you can use both drug concurrently. So latanoprost was actually your drug for PG analogs, and these caused hypertrichosis. Okay, and it also caused heterochromia iritis. It caused macular edema. Okay, and it there was side effects, right? Yeah. And beta blockers you can use concurrently. And if you do not attend this thing, then you can use certain drugs like brimonidine or dorzolamide. So dorzolamide, brinzolamide, epaclonidine are alpha adrenergic blockers, alpha agonist, and brimonidine are actually what group of drug? Brimonidine. Epaclonidine, epaclonidine, brimonidine are alpha adrenergic agonists, right? And after that, what you'll use certain like carbonic anhydrase inhibitors. You can use athlete, you can use myotics, and if the compliance is very low, then you can go for this one, surgery. And natasodil are newer drugs, okay, because they tend to like topical steroid associated glaucoma. Natasodil becomes a very good drug. Okay, natasodil. So this completes our video on the drugs of glaucoma. Now we'll talk about the secondary glaucoma. Okay, secondary glaucoma. So these are important. Secondary glaucoma, it's often asked in examination, sometimes not in the university examination, but in your like PG MCQ, sometimes it's asked. Okay, and I will show you diagrams. See, this was the diagram of resolved IOP, which we resolved this one resolved acute congestive glaucoma, which you can actually make in your copy. So what you can see here is, you can see that in this picture I'm making iris atrophy, right? Iris atrophy, I'm making iris atrophy. And you can see that in this number 3 I'm making that irregular pupil, okay, irregular pupil. This diagram is irregular pupil. This is your iris atrophy. Okay, this is your Descemet's membrane fold that I'm illustrating, and over here I'm making glaucoma flecken. Okay, glaucoma flecken, dispersion of the pigment of the cornea, as well as what next, dispersion of pigment on the cornea, and iris atrophy was the Vaux triad, right? Vaux triad was breach in the Descemet's membrane of the cornea. So cupping means this one, cupping. Okay, so you can make like this kind of diagram. So next topic is actually your pseudo-exfoliation syndrome. Before pseudo-exfoliation syndrome, I'd like to talk about one condition which is known as pigmentary glaucoma. So pigmentary glaucoma, so remember, pigmentary glaucoma, they come with Xenthamer's line is there, no? Pigmentary glaucoma. Oh yeah, pigmentary glaucoma. No, see, understand. Okay, so pigmentary glaucoma. So what is pigmentary glaucoma? History of pigmentary glaucoma. So what happens is, a person, young adult, he comes to the he goes to the gym, and after coming out from the gym, what happens is, after coming out from the gym, he has certain eye pain. Okay, that happens because here, yes, this iris is so much moving. Okay, this iris is so much moving that from the iris, the pigments are being dispersed. The pigments come to the area of the cornea, and these pigments, they go to the angular this area, and then they occlude. Okay, they occlude. So same mechanism shown here also. So iris pigmented blocks the TM. Okay, and this iris pigments is actually termed as Krukenberg spindles. Okay. So secondary open angle glaucoma, known as pigmentary glaucoma, is characterized by severe homogeneous trabecular meshwork pigmentation, and there's Krukenberg spindle which is seen. This usually young males coming out from the gym, and they certainly have eye pain, right? And what happens is transillumination defect. So what does that mean? That means the more light it passes through the iris. So iris is actually like a curtain, right? So it closes and opens, right? And it's like a curtain. So more light it passes through the iris, and because of which there is a transillumination defect. Okay. And whenever you talk about ultrasound biomicroscopy examination, you will see something which is known as reverse glaucoma. That means normally because of angle closure glaucoma, so I'll make it right here. Normally because of angle closure glaucoma, the iris would have been like this, like, so there's a bowing out, there's an anterior bowing of the iris like this, no? But what happens in this case is the bowing will be posteriorly. Okay, so this is also known as reverse glaucoma. Okay, this is also known as reverse glaucoma. So you can see it in this diagram. So you can see that, no? Reverse glaucoma. So ultrasound biomicroscopy image shows concave configuration of the iris. This is known as reverse glaucoma. And any pigments dispersion at the equatorial area near the zonular insertion is known as Xenthamer's line. You can just remember Xenthamer's line, okay? And medical therapy, you can go for anti-glaucoma drugs, or you can also go for argon laser trabeculoplasty, okay? Xenthamer's line and Jim transformation defect, pigment in the trabecular meshwork, Krukenberg spindles. These are all about pigmentary glaucoma. Let's talk about pseudo-exfoliation syndrome. Now, what is pseudo-exfoliation syndrome? The pseudo-exfoliation syndrome is the most common cause of secondary glaucoma. Okay, it's the most common cause of secondary glaucoma. So what happens in pseudo-exfoliation syndrome? Certain dandruff-like particles, okay, so gray-white dandruff-like particles, they are actually seen in your eye, and these dandruff-like particles, they are responsible for, the lens is basically moved because of this dandruff-like particles, and that leads to subluxation of lens, okay. So pseudo-exfoliation syndrome, trauma, and of course, I also talked about certain diseases like Marfan syndrome or homocystinuria or Will-Matrix-Hany syndrome. These are responsible for causing subluxation of lens. So the most common cause of secondary glaucoma is actually pseudo-exfoliation syndrome, right? And dandruff-like gray-white fibrillar material get deposited in the lens capsule, suspensory ligaments, and back of the cornea, and they block the tapetal meshwork, right? This material is from abnormal extracellular matrix metabolism tissues. Okay, so basically extracellular matrix metabolism tissues. Okay, so extracellular matrix metabolism tissue. That's why it is known as exfoliation. Okay. and it leads to secondary open angle glaucoma. You can understand some point is important, okay? Don't. And malignant glaucoma means, suppose whenever after doing certain eye procedure, if the ciliary process it goes towards the vitreous, so aqueous will flow towards vitreous and it will push the lens forward. That will lead to malignant glaucoma. Okay, and that's it from glaucoma. So that was more important to understand. Thank you everyone. So we have completed our topic for glaucoma. So moreover we have completed. Thank you so much. Thank you.